Greetings, I'm the dentist. Welcome back to DENTAGENDA. This is Chapter 3, Pediatric Dentistry. These are the points included in this chapter video series, and in this tutorial we will discuss abnormalities of teeth regarding eruption and exfoliation, number, structure, form, and color. Starting with abnormalities of tooth eruption and exfoliation. Natal teeth. Natal teeth are teeth that are present when a baby is born. They are not the same as neonatal teeth that erupt in the child's mouth during the first month of life. Usually, these are members of the primary dentition and can sometimes be supernumerary. They should be retained if a radiographic examination reveals that it is the main primary tooth. Most frequently, they appear in the lower incisor region. Because of limited root development at that age, they are often mobile and weak. If in danger of being inhaled by the child, or they cause problems with breastfeeding and discomfort for the mother, they can be removed, usually removed with no local anesthesia, or some topical local anesthetic gel or spray can be applied. Teething. As eruption of the primary dentition coincides with a diminution of circulating maternal antibodies, teething is often blamed for systemic symptoms. However, local discomfort and disturbed sleeping may accompany the actual process of eruption. Several teething preparations are available in the market, which usually contain a combination of analgesic and antiseptic and anti-inflammatory agents for topical use. Having something hard to chew on may help, like teething rings. Some are designed to be cooled in the refrigerator, which can enhance their soothing ability. Eruption cyst. This is caused by an accumulation of fluid or blood in the follicular space overlying the erupting tooth. The presence of blood gives the bluish hue. Most of these cysts rupture spontaneously, allowing the eruption to proceed, but rarely it may be necessary to marsupialize the cyst surgically. And as you can see, it can mostly form in the upper incisor region, but it can also form in other places like canines and molar regions. Failure of or delayed eruption. Disruption or disturbance of normal eruption sequence and asymmetry in eruption times of contralateral teeth for longer than 6 months than normal warrants further investigations. It must be remembered that there is a wide range of individual variations in eruption times. However, developmental age is more important in assessing delayed eruption than chronological age. There are general and local causes that can lead to that problem. General causes like hereditary gingival fibromatosis, Down syndrome, Gardner syndrome, hypothyroidism, cleidocranial dysostosis, and rickets. Now to the local factors that can lead to delayed eruption. Congenital absence of the tooth is the most likely cause for failure of appearance of tooth, as in hypodontia or oligodontia. Crowning, that prevents the eruption of the impacted teeth below and can be treated by extractions. Retention of the primary tooth due to failure of root resorption and can be treated by extraction of this primary tooth after confirming that the permanent successor is present. Supernumerary tooth is the most likely reason for failure of eruption, as in hyperdontia. Crown root dilaceration, dentodorous cyst, and trauma to primary tooth leading to lateral or apical displacement of the permanent incisor. Abnormal position of crypts that can be treated by extraction or orthodontic alignment. Another local factor for failure of eruption is ankylosis. It is a pathological fusion between the alveolar bone and the cementum of a tooth without the presence of PDL. Regarding clinical examination, when an ankylosed tooth is tapped by an instrument handle, the sound produced by this tapping is described as high, sharp, or solid sound, rather than being dull and cushioned as in normal teeth. Infraoccluded or ankylosed primary molars occur where the primary molar has failed to maintain its position relevant to the adjacent teeth in the developing dentition and is therefore below the occlusal level of adjacent teeth. Often cause disruption in normal resorptive repair cycle of exfoliation. This is usually self-correcting if the permanent successor is present and not ectopic, and the affected tooth will exfoliate at the normal time. However, where the premolar is missing or ectopic, where the infraoccluded molar moves below the contact of the adjacent teeth or appears in danger of disappearing below their gingival level, extraction may be indicated. Another factor would be ectopic eruption, meaning that the permanent tooth would erupt in an abnormal position. Ectopic eruption of first permanent molars most commonly occur in the upper arch, against the distal end of ears. It occurs in 2 to 5% of children, and it is an indication of crowding. In younger patients, like younger than 8 years of age, many could self-correct. But if still present after 4 to 6 months or in older children, an orthodontic separating spring may allow the cyst to erupt freely. In more severe impaction, like canine impaction, they should be kept under observation. If the E becomes abscessed or the cyst is in danger of becoming carious, then the primary tooth should be extracted as soon as possible, and the resulting space loss can be dealt with later as a part of the overall orthodontic treatment, or it can be avoided by the use of a space maintainer. Premature exfoliation is another local factor for failure of eruption. The most common reason for early tooth loss is extraction for caries. Traumatic avulsion is another cause, but it is less common. In case of traumatic avulsion, the avulsed tooth should be cleaned with saline to remove any dirt or foreign bodies, but never attempt to remove the tissues around it. Keep it in saline, milk, or in the patient's mouth in saliva for maximally 1 hour until reaching the dentist to replant the tooth and fix it with the neighboring teeth. Keep in mind that teeth in such cases are more vulnerable to be ankylosed. Tooth loss can more rarely be attributed to systemic diseases, like neutropenia or leukemia. They result in an abnormal periodontal attachment and thus premature tooth loss. Alveolar bone loss in young children is a serious finding and warrants urgent referral to specialist. Now to the abnormalities of tooth number. Anodontia means complete absence of all teeth, and it is a rare condition. Hypodontia or oligodontia means developmental absence of one or more teeth, but not all. Prevalence in primary dentition is 0.1 to 0.9%, and in permanent dentition 3.5 to 6.5%. In Caucasians, most commonly affected teeth are 8s, then laterals, and then lower 5s, often associated with smaller than average tooth size. Peg-shaped laterals often occur in conjunction with the absence of the contralateral lateral incisor. Note that canine migrates down guided by the distal aspect of the lateral. So when the lateral is absent, peg-shaped, or small-rooted, it is important to monitor the maxillary canine for signs of ectopic eruption. This condition affects females more than males. Hypodontia is often familial, and it can be associated with ectodermal dysplasia or Down syndrome. Treatment. In primary dentition missing teeth, no treatment is needed to replace them, maybe just a space maintainer to hold the space for the permanent successor. In permanent dentition missing teeth, it depends on the crowding or malocclusion and if it can be replaced or not. And in case of to be replaced, fixed restorations as bridge work or dental implants will always be options depending on the case. If the 8 is missing, no treatment is needed to replace it. If the 5 is missing, however, and keep in mind that it can sometimes develop later, you have two options. If the patient's teeth are already crowded, extract the E's, either at around 8 years of age for spontaneous space closure or later if the space is to be closed as a part of an orthodontic treatment. And if the lower arch is well aligned or spaced, consider preserving the E's and do a bridge work or implant later in the preserved space. And if the E's have no pathology and long-rooted, they can sometimes be maintained into the adulthood as a replacement for the missing 5. Hyperdontia. Hyperdontia, also known as supernumerary teeth. Prevalence in primary dentition is 0.8% and in permanent dentition 2%. It occurs most frequently in premaxillary region and can be associated with cleidocranial dysostosis. Supernumerary teeth in primary dentition is usually followed in 50% of cases by supernumerary teeth in permanent dentition, so warn the parents. It affects males more than females. The etiology theories include offshoot of dental lamina and third dentition. Classification is either according to the shape or position and orientation. According to the shape, a supernumerary tooth could be conical or peg-shaped, tuberculate or barrel-shaped, supplemental that resembles the shape of the normal tooth, or odontome. According to the position, it is called mesiodense when present between the central incisors, distomolar when present distal to the third molar, and paramolar when situated buccally or palatally to one of the maxillary molars. The effects of hyperdontia or supernumerary teeth on dentition and how to treat them. It has no effect if unerupted, but it must be kept under observation, radiographic review occasionally to exclude any cystic changes or damage to the adjacent teeth, or both, which is relatively rare. If it erupts, extract it. In case of crowding, extract the tooth if supplemental, and in that case, extract the tooth with the worst crown or root form, or the tooth with the most displaced apex. It can cause rotational displacement. Extraction of supernumerary teeth and fixed appliances is used. But in case of displacement, there is always a tendency for relapse. Failure of eruption. Extract supernumerary and ensure sufficient space for unerupted tooth to erupt. You may require extraction of the primary teeth or permanent teeth, and orthodontic appliance is used. Then wait. The average time for eruption in these cases is about 18 months. If after 2 years the unerupted tooth fails to erupt despite the sufficient space, you may require conservative exposure and orthodontic traction. Children with hypodontia will often benefit from specialist multidisciplinary management, coordinating pediatric dental, restorations, and orthodontic management. Abnormalities of tooth structure. starting with disturbances in structure of enamel. Enamel usually develops in two phases. First, as an organic matrix, and second, mineralized tissue. Disruption of enamel formation can therefore manifest as follows. Hypoplasia, caused by disturbance in matrix formation and is characterized by pitted, grooved, or thin enamel. Hypomineralization or hypocalcification is a disturbance of calcification. Affected enamel appears white, yellow, or brown and opaquer than usual. May become more discolored post-eruptively. Affected enamel may be weak and prone to breakdown. Most disturbances of enamel formation will produce both hypoplasia and hypomineralization, but clinically, one type usually predominates. We will go through these points regarding enamel structure disturbances. Some etiological factors for enamel structure disturbances. Localized causes, like infection, trauma, irradiation, or idiopathic causes. Generalized causes, like environmental factors that can cause chronological hypoplasia. Prenatal causes, like in case of rubella and syphilis. Neonatal, like prolonged labor or premature birth. And postnatal factors like measles, congenital heart diseases, fluoride, and nutritional factors. Hereditary can affect teeth only, like in case of amelogenesis imperfecta, and can be accompanied by other systemic disorders like Down syndrome. Chronological hypoplasia. It is so called because the hypoplastic enamel occurs in a pattern related to the extent of tooth formation at the time of the insult. Due to its later formation, lateral is affected nearer to the incisal edge than central or canine. Treatment of hypomineralization or hypoplasia depends on the extent and severity. In posterior teeth, small areas of hypoplasia can be fissure sealed or restored conventionally, but more severely affected teeth may require crowning. Stainless steel crowns can be used in children as a semi-permanent measure until they can be replaced later on in life. In anterior teeth, small areas of hypoplasia can be restored using composites, microabrasion, or resin infiltrates, but larger areas may require veneers or crowns. Molar incisor hypomineralization. The etiology for this case is unknown, and the prevalence has increased over the past 2 decades in developed countries. Primarily affects sixes, but 50% of population also have defects on permanent incisors. The affected sixes have hypomineralized defects of enamel, varying from discoloration to severe enamel dysplasia with post-eruptive breakdown. Sensitivity may increase, and secondary caries may increase as well. Defects may affect anything from 1 to all sixes. Yellow or white opacities on the buccal surfaces of the affected incisors are apparent. Distribution often asymmetrical, and there is no clear chronological pattern. Incisors are less prone to enamel breakdown than sixes. That treatment options include intracoronal restorations, stainless steel crowns for children, microabrasion, vital bleaching, resin infiltrates, or extraction. Depending on aesthetics and prognosis, extraction of poor quality first permanent molars can be decided. Partial composite veneers can be considered to repair post-eruptive breakdown of incisors. Hypomineralized second primary molars. is a developmental defect of dental enamel that shares features with molar incisor hypomineralization that we have just mentioned. It may lead to post-eruptive breakdown and secondary caries. Recent studies suggested that it is a predictor that molar incisor hypomineralization may be more likely to occur in the permanent dentition. Amelogenesis imperfecta. Many classifications exist, but generally these are classified by the type of enamel defect and/or the mode of inheritance. There are now known to be mutations in at least 15 different genes that are associated with amelogenesis imperfecta, usually both primary and secondary dentitions, and all the teeth are affected. The different subgroups give rise to a wide variation in clinical presentation, ranging from discoloration to soft or deficient enamel. It is therefore difficult to make general recommendations, but it is wise to seek specialist advice. Treatment include stainless steel crowns and composite resins can be used to maintain the molars prior to a more permanent restoration when the child is older. The main types of amelogenesis imperfecta include hypoplastic. In this case, the enamel may be thin, smooth, or rough, or pitted, and it is most commonly autosomal dominant inheritance. Enamel renal syndrome. It's a rare hypoplastic amelogenesis imperfecta. Clinical features include severely hypoplastic and discolored enamel, semilunar shape of incisal edges, intrapulpal calcifications, hyperplastic dental follicles, delayed eruption, and gingival hyperplasia. Hypocalcified. Enamel appears dull, lusterless, opaque white, honey or brown colored. Enamel may break down rapidly in severe cases. Sensitivity increase, calculus formation increase as well, and it might be autosomal dominant or recessive inheritance. Hypomaturation. Mottled or frosty-looking white opacities and sometimes be confined to incisal third of crown, giving the snow-capped teeth appearance. Now to the disturbances in structure of dentine. Disturbances in dentine structure include dentinogenesis imperfecta, dentinal dysplasia, regional odontodysplasia, vitamin D resistant rickets, and Ehlers-Danlos syndrome, which is a group of disorders that affect connective tissues. Most syndromes are quite rare, but dentinogenesis imperfecta, which is a hereditary opalescent dentine, is a more common case, in which both primary and secondary dentitions are involved, although later formed teeth may be less affected. Characters of teeth in dentinogenesis imperfecta include teeth may appear opalescent brown or blue hue, bulbous crowns, short roots, and narrow flame-shaped bulbs. The amelodentinal junction is abnormal, which results in the enamel flaking off, leading to rapid wear of the soft dentine. Children with opalescent teeth may also have brittle bone diseases. Early recognition and treatment of amelogenesis and dentinogenesis imperfecta is important to prevent rapid tooth wear, and both follow the same lines of treatment. The main types of dentinogenesis imperfecta are 1 and 2. Type 1 is associated with osteogenesis imperfecta, and type 2 affects the teeth only. Disturbances in structure of cementum. Hypoplasia and aplasia of cementum are uncommon, but aplasia, which is the complete failure of cementum formation, can occur in case of hypophosphatasia and results in premature exfoliation of teeth. Hypercementosis is relatively common and may occur in response to inflammation, mechanical stimulation, or Paget's disease, or can be idiopathic. Concrescence is the uniting of roots of two adjacent teeth by cementum. Children with developmental dental anomalies will often benefit from specialist multidisciplinary management, coordinating pediatric dentistry, restorations, and orthodontic managements altogether. Prevention is a priority in children with developmental dental anomalies to minimize the risk of primary and secondary caries, tooth surface loss, and periodontal diseases. Now let's discuss abnormalities of tooth form. Double teeth. It includes either fusion or gemination. Fusion means two separate teeth appear as one tooth due to fusion between the two teeth germs. And gemination means one single tooth appears as two teeth due to splitting of the tooth germ. As fusion can take place between either two normal teeth or one normal tooth and a supernumerary tooth, which is less common, counting the number of teeth will not always give the correct etiology. Both primary and secondary dentitions can be affected, and the prevalence in secondary dentition is 0.1 to 0.2%. Treatment for aesthetic purposes should be delayed to allow pulpal recession. If the tooth has two separate bulb chambers and root canals, like in case of fusion, separation can be considered as a treatment option. And if the fusion is between a normal tooth and a supernumerary tooth, then the supernumerary portion can be easily extracted. Where the tooth has single bulb chamber, like in gemination, sometimes the tooth can be contoured to resemble two separate teeth, although this option is not recommended since there won't be a normal neck or papilla appearance. Another option would be to reduce the bulk of the crown. Number 2. Macrodontia or megadontia simply means larger tooth than normal. Generalized macrodontia is rare but is unilaterally associated with hemifacial hypertrophy. Isolated megadont teeth are seen in 1% of secondary dentitions. Number 3. Microdontia, meaning that smaller tooth size than normal. Prevalence in primary dentition is less than 0.5% and in secondary dentition is 2.5%. Peg-shaped laterals often have short roots and therefore they are thought to be a possible factor in palatally displaced canines. Eighths are also commonly affected. Number 4. Densindenti. This is really a marked palatal invagination which gives the appearance of tooth within a tooth. Usually affects the laterals, but can also affect premolars. Where the invagination is in close proximity to the pulp, early pulp death may occur. Fissure sealing of the invagination as soon as possible after eruption may prevent this, but is often too late. Extraction may be required in some cases. Other options include root canal treatments, but note that it can be difficult. Pulpotomy and apical treatments are also options. Number 5. Dilaceration. This describes a tooth with a distorted crown or root form. Usually affects upper central incisors. There are two types depending upon the etiology. It can either be developmental or traumatic. Developmental dilaceration, crowns are turned upward and labially, and the enamel and dentine forms are regular, and usually no other teeth are affected, and it is more common in females. In traumatic dilaceration, crowns are turned palatally. Disturbed enamel and dentine formation can be seen. In traumatically induced type, the main cause is the intrusion of the primary incisor, resulting in displacement of the developing secondary incisor tooth germ. The effects depend upon their developmental stage at the time of the injury. The treatment depends upon severity and patient cooperation. If mild, it may be possible to expose the crown and align orthodontically. Number 6. Turner tooth. This term is used to describe the effect of disturbance of enamel and dentine formation by infection from an overlying primary tooth, which therefore usually affects premolar teeth, since the E's and the D's are vulnerable to infection. The treatment is the same as for hypoplasia. Number 7. Taurodontism. Tauro means pull-like. It may occur in some cases of amelogenesis imperfecta. Radiographically, the affected tooth has elongated pulp chamber that resembles the bull's head. No treatment is required, but in case of endodontic treatment, the treatment may be complicated, so occasionally extraction is indicated. Last but not least, abnormalities of tooth color. Change in the normal tooth color can be attributed to either intrinsic or extrinsic factors, starting with extrinsic stainings. These are extrinsic factors that can lead to changing of the normal tooth color, and they can be removed and can be avoided by prophylaxis. Green, black, orange, or brown stains can be seen. It may be formed by chromogenic bacteria, smoking, or can be dietary in origin. Also, the regular use of chlorhexidine mouthwash can lead to brown stainings. Where the staining is associated with poor oral hygiene, demineralization and roughening of the underlying enamel may make the removal of the stains more difficult. The treatment includes a mixture of pumice powder and toothpaste, or an abrasive prophylactic toothpaste together with a bristle brush should be enough to remove the stains. Meticulous oral hygiene instructions can help to prevent staining returning, but recurrence is unfortunately relatively common. Intrinsic stainings. This can be caused by different factors. Firstly, changes in the structure or thickness of the dental hard tissue itself, like in case of enamel opacities that can give whitish, yellowish, or brownish opaque patches. In case of incorporation of pigments during tooth formation, like in case of tetracycline staining leading to blue or brown stains. Also in case of porphyria, reddish or brown stains can be seen. A third cause is diffusion of pigments into the hard tissues of the tooth after complete formation, like in case of pulp necrosis. It leads to gray or yellow stain, mostly in the central incisors due to trauma. Also, the placement of intracanal root medications can lead to gray discoloration of the tooth. In case of enamel opacities, note that these are localized areas of hypomineralized or hypoplastic enamel. Fluoride is only one of a considerable number of possible etiological agents. 6 possible approaches can be used to treat this case. Approach number 1. Acid pumice abrasion technique is effective for some types of diffused surface enamel defects. 2 methods are available. Don't forget to take preoperative photos to monitor the improvement. Method number 1. Hydrochloric acid technique. A mixture of 80% hydrochloric acid and pumice is applied to the affected area using a wooden stick. Careful isolation with rubber dam. Use a neutralizing agent like sodium bicarbonate and protect the soft tissues. The mixture is rubbed into the surface for 5 seconds and then rinsed away. These 2 steps are repeated maximally 10 times. Note that this process can remove less than 0.1 millimeters of the enamel thickness. Repeat until the desired color change is achieved. The enamel is then polished and a fluoride solution is applied. Inform the patient to avoid highly colored foods or drinks for 48 hours. Method number 2, phosphoric acid technique. It is slower but potentially safer. A number of variations of this technique are in use. A commonly used method is to etch with 30 to 50% orthophosphoric acid for 1 to 2 minutes. Wash, then use pumice and water slurry with rubber proofy cup for 1 minute. Take care not to overheat the tooth. Wash, repeat etch and pumice stages twice, washing in between. Dry the tooth and apply topical fluoride solution. Avoid pigmented varnishes. This process can be repeated up to 2 times, but leave at least 6 weeks before each repeat to check for improvements. Approach number 2. Resin infiltrate is a valid and well-supported approach of treating enamel opacities. There are various systems available, but commonly the tooth is etched with hydrochloric acid, dried with ethanol prior to application of methacrylate-based resin. Approach number 3. Bleaching or tooth whitening. The patient should be at least 18 years old of age to avoid pulpal sensitivity or damage. Approach number 4. Veneers. It shouldn't be considered before the gingival position is stable, so at least after 16 years of age. Approach number 5. Crowns. Anterior crowns shouldn't be considered before the gingival position is stable, so at least 16 years of age. Approach number 6. Localized composite restorations in the affected areas, including composite veneers. Thank you for watching. Don't forget to subscribe. I'd like to have you here for more videos. And follow us on Instagram at DENTAGENDA for extra tips and tricks.